Good evening, everyone, and thank you for being here with us. My name is Eliana Gonzalez, the Global Marketing Manager at Osseo. It is my pleasure to introduce our presenter who will share insights into one of our fastest growing products this year, the Osteofiber Minimally Invasive All Natural Bunion Correction Technique using the 4-5 beveled threaded trimmable fixation nail. Dr. Stephen K. Neufeld is a board-certified orthopedic surgeon and founder of the Orthopedic Foot and Ankle Center, OFAC, in Falls Church, Virginia. He specializes in total ankle replacements and minimally invasive foot and ankle surgery. OFAC is the Washington, D.C.'s area's first comprehensive center for foot and ankle care, featuring a team of orthopedic physicians, physical therapists, athletic trainers, and podiatrists. With 26 years of experience, Dr. Neufeld is a distinguished foot and ankle expert and the first in the region to perform the minimally invasive bunion corrections. He graduated from the University of Pittsburgh School of Engineering and earned his medical degree from Hahnemann University in Philadelphia. Dr. Neufeld completed his orthopedic surgery residency at Ohio State University and a fellowship in foot and ankle orthopedic surgery at Union Memorial in Baltimore. Dr. Neufeld, thank you for being with us tonight.
All right. Thank you, Eliana. That's a very nice introduction. Well, hello, everybody. Good evening. I am very excited about this webinar. This is one of my passions, and I'm excited to share my findings and some research we're doing, and really some of the cutting edge stuff that is happening in the foot and ankle world. These are my disclosures. I do some work with Osseo and some other companies related to the foot and ankle world. Um, and why this really kind of turned me on was that I've been doing bunion procedures for a long, long time. And every time I meet a new surgeon, podiatry, orthopedist, I always say, what kind of bunion surgery do you do? And some say, well, I do open chevrons and I do scarfs and I do lapiduses. So when I was training a while ago, it was one thing, but over the years, it just seems like more and more operations pop up. So I actually typed into ChatGPT a couple weeks ago and I said, list for me the different bunion procedures, and there were over 100 procedures that have been described, so it's kind of crazy. So then the first question pops up. Well, doc, why is MIS, minimally invasive surgery, a thing? If there's so many procedures to achieve the same results, which is correction of a bunion, then why do we need, and why do you want to talk about MIS surgery? So let's talk about this. I want to talk about my journey. I've been doing bunion correction surgeries and forefoot surgeries for, like I said, over 20, 25, 26 years. And when I was trained in Baltimore, for a moderate to severe bunion, we would do a proximal osteotomy, like an open Ludloff. But most cases was a chevron or a distal osteotomy, which is a small procedure, but it was still open. And then anytime there's any arthritis or instability in the midfoot, we would then do a lapidus. And that was the tried and true technique, and it's still the tried and true technique for many, many people around the world. Whether you do a Ludloff or an open chevron or opening wedge, there's a million of these operations. But what I noticed as I went to practice by myself is that though these surgeries did do the corrections and they did achieve the results most of the time, it really was not a home run every time. There were complications such as wound problems and stiff joints, and it really eventually most patients were happy. But I was shocked that such a simple operation led to very long recoveries, and it took a long, long time for patients to become happy. So in 2019, I discovered the group MIFAS, Minimally Invasive Foot and Ankle Society, and some of my friends said, Steve, you should come over to Morocco to check out this Congress. And I was absolutely amazed. There were 6 of us in the United States. Most people from this conference were from around the world, and I was seeing the most unbelievable cases and the most unbelievable results from surgeons around the world. And thought to myself and talked to my friends over there, like, what are we missing, guys? This is something happening around the world. The U.S. is really behind the scenes. So when I came back to the States and I dove into this, I said, all right, how am I going to get into this whole thing? And this is early on when we really weren't doing many of these at all. I started doing some cadaver labs. A few of the industries early on started putting on courses. There were a few books at the time that came out, mostly out of Europe. There were some technique guides that came out. And really what came down to me getting into this was just practice. Lots and lots of practice. And that would be my advice we'll talk about at the end, is just you got to get in there and you got to practice. Because when we're taught in residency and fellowship how to do foot and ankle surgery, it's using a saw, it's making incisions, and the techniques that we're going to talk about tonight and the techniques needed to do minimally invasive surgery are new for us in America. We're not trained to do this. Most residency programs in the US do not have minimally invasive surgeons, and it is and becoming even more and more popular and will become the gold standard pretty soon. So to date, just to put in context, I've done 600 of these cases, so I feel pretty confident that anybody could do it if I could do it. So why MIS bunion surgery? Well, everybody has unfortunately seen these photographs of wound dehiscences and infections and arthrofibrotic and stiff joints. Look at the incision on the top from an open proximal osteotomy versus one on the bottom from minimally invasive surgery. This my anecdotal data is that these surgeries, these patients do great. They have less pain, less swelling, and less complications. And there is literature to support that. Lots of articles. I just pulled a few here, but we have shown in the foot and ankle world that there's less pain, there's less stiffness, there's less complication rates in terms of wounds, better cosmesis, and patients do great. And I will tell you, in 26 years of practice, my practice and my office has never hummed as smoothly and been as happy and smooth that it has since I jumped into MIS bunion surgery. I get patient reviews online all the time saying how wonderful it was and how great the recovery is. So I would really, if anybody's even contemplating jumping into this world of MIS bunion surgery, I would highly encourage you to jump in and learn. Let's spend a minute or so to talk about the history of it, because I think that's important. It's not new in the world, and it's really actually not even new in the United States. It just hasn't really caught on. In the 1970s, it was first described with an intracapsular osteotomy using a burr, no fixation. Unfortunately, these led to many complications, malunion, shortening, and it was pretty much abandoned. The results were not able to be reproduced, and pretty much the pediatric and orthopedic world, foot and ankle surgeons just dropped this operation. But then in the 2000s, there was a rebirth of it. Giannini out of Europe described his operation called the Siri. We tried to bring those over to the United States, actually, when I was in fellowship. But really, we had troubles. There were delayed unions, there was avascular necrosis, pin complications, there was an elevatus with malunions, and the procedure really didn't catch on at all. And there were some publications out of the U.S. that really just put a kibosh on that operation. It really wasn't until 2011 when two colleagues of mine, Redfern and Vernoir of France, described what they called the MICA, the minimally invasive chevron and Aiken osteotomy. And this really was revolutionary. This was an extracapsular, minimally invasive osteotomy with a burr. It was done at the metaphyseal-diaphyseal junction. There was a minimal soft tissue dissection, and it was essentially the same operation as we learned to do open, without big incisions. And they created and designed some specialized screws that really changed and revolutionized this operation. The fourth generation came along as more and more surgeons in the U.S. adopted this operation. Now they were described as transverse osteotomies instead of the chevron, where we learned that you can make a multiplanar rotational correction, which I'll talk about in a few minutes. We were able to do larger deformities. It was still extracapsular, still rigid internal fixation. But in this fourth generation, the companies and the surgeons started developing jigs and all kinds of specialized equipment specific for minimally invasive bunion surgery. And we're about to launch into the fifth generation, which we'll talk about. But this is where we are at now in 2026. So again, why do we need MIS osteotomies? Why? Well, it's all about outcomes. It's not about the training necessarily, where we were trained to do something different and now we have to do something that we think may be better. It's that we were trained to do something, but the outcomes with this minimally invasive approach is absolutely better. There's no question about it. I'm just going to go through a couple studies here. Here's a study early on that compared open osteotomies with minimally invasive osteotomies. It showed with 29 MIS versus 58 open, with a reasonable follow-up, there was less pain and lower wound complications. The x-rays and the results were the same clinically. There was another study that, again, looked at open osteotomies, chevrons, versus minimally invasive osteotomies. 2 years, this one showed no outcomes that were problematic in the osteotomies that were done minimally invasive, no difference in the x-rays, and this is now showing a trend where these open osteotomies may not do as well as the minimally invasive osteotomies. Again, now we're getting further along. There was a 5-year follow-up. There's an international study Australian and UK surgeons that looked at 78 feet. Um, Very great success with many patients doing terrific with highly satisfied results, very low recurrence rates, very low complications. Then after a few years, when I was got into this, I published a paper. I think mine was one of the first papers in the U.S. to come out looking at minimally invasive bunion surgeries. One of the critiques back then were that the learning curve was very steep. It was very difficult to look at this. So my fellow at the time in residence looked at my first 95 patients, and after about a year, the patients had great clinical and radiographic outcomes. We only had a 5% reoperation rate. Those were hardware removals in old women with osteopenic bone. We took those patients to surgery, took out their screws. We didn't lose any corrections. We had one superficial infection that cleared up with a little IND, and in general, the foot width went smaller, and the patients were very happy. So this really turned me on to the world of MIS bunion surgery. And after my first 100 patients, I'm like, I am sold. This is the way to go. So then we started pushing the envelope in the U.S. and in Europe as well. We were taught that with big deformities, we need to do a Lapidus or a proximal osteotomy. Well, the question is, can you actually achieve results with minimally invasive techniques on these massive deformities? So here's a case out of HSS with an IM angle of 14 degrees, average hallux valgus angle of 30 degrees, large angles. Another study that was published in 2023 with a hallux valgus angle of 41 degrees. So as the years went on, we all of a sudden started seeing papers with larger and larger deformities with very low recurrence rates and very low complication rates with terrific corrections. And I think at this point, our algorithm has changed, and the size of the deformity, the traditional training of measuring IM angles and measuring hallux valgus angles, really, I think is an old way of approaching these cases. And I think we can actually do big surgeries and stuff that we traditionally were unable to do with small incisions. So this has been my kind of mantra, and what's guided me over the last couple decades is really do the best you can do until you know better. And then when you know better, just do better. And MIS bunion surgery is better, and that's what we all really should be doing. And hopefully at the end of this talk, I'm going to convince you to at least try it, and I imagine that you will never want to go back to open surgery. So we talked about the first through fourth generation, and I'm going to talk about the fifth generation, which I think is where we are right now. And the fifth generation uses osteofiber screws, which is terrific. The days of metal, where we relied on the metal fixation, are really behind us. And now we are able to use biointegrative fixation and really advanced techniques and advanced ways of fixing these osteotomies without the problems of metal. These are beveled screws, just like the metal screws. They're disposable kits, so it decreases the number of trays, and it makes it much easier. And what are biointegratives? You know, we're trained to use metal in the foot and ankle world. Well, biointegratives are materials and screws that are made by the company that actually integrate into the bone and tissue. So you imagine when we put metal in, the strongest point in time is when that metal screw first goes in. And then over time, we know that the bone resorbs around the metal, and eventually the bone remodels and becomes strong. But unlike metal, when you use these osteofiber or biointegrative screws, not only do you get immediate strong fixation like you do with metal, but the bone actually grows into the screw itself or the nail. It fully integrates. So actually the construct becomes stronger over time as opposed to resorbs around the implants. And this has vast implications all over surgery, all over the foot and ankle, and all over the body actually. But we're going to focus on using this technology for bunion surgery because I really think it's truly the next generation of fixing these deformities. The amazing thing about these osteofiber implants is that they have no reaction. There's no inflammatory reaction. Some patients we put in these screws and they have nickel allergies, or they have problems with metal, or they get these hyperreactive, hyperswollen reactions, and we take the metal out, or they back out and you have to remove the metal. People, it's not the majority of cases, but enough times a year we all have had our metal problems that it would be nice not to have any problems at all. And with these osteofiber implants, the bone grows into it. There's no adverse response, and you can tell your patients that within 2 years, those screws are gone. Only nature remains, the natural bone, which is really quite amazing and quite appealing to the majority of patients that I run into. Um, there's a specialized screw called the TTFN. It's a beveled screw system made for this operation and other areas of the metatarsals or the foot and ankle where you'd want a beveled screw. And we'll talk about it. It comes as a kit, which is very nice. You don't need any big trays with lots of parts. You open up one of these kits, and in the kit is everything essentially you need to perform this operation, along with some burrs on the side and obviously the machine. And we're going to talk about that as well. Briefly, this is a 4.5 millimeter nail, which is standard in the industry. It's a conical head. It's a variable pitch, so you get minimal compression. That's when we do these osteotomies, we're not looking for compression. We're looking for stability. They're fully threaded, so you get purchase on both sides of the osteotomy, which is essential for the stability. Let's go through the technique of using these osteofiber screws in this technique. So we're going to go through a case. This is one of my cases from a number of years ago. I would imagine we would call this one a moderate to severe bunion deformity along with a crossover toe. And I would think many people would probably do a proximal osteotomy on this one, or maybe even a lapidus. These patients come to the operating room, and the setup for a MICA or a minimally invasive chevron Aiken or a MIA, minimally invasive all natural, is all the same. The patient's foot is placed off the end of the bed on a bump. The foot is really hanging free in space so that the mini C-arm can be used to rotate around the foot, which is very important because minimally invasive surgery is all about visualization on an X-ray. We're not opening these incisions and looking at the osteotomy. We're actually looking under X-ray. So it's important the setup to allow this to work smoothly. For minimally invasive foot and ankle surgery, the key are the tools. This is different than we've traditionally been trained. It's all about the burr. And the burr is a low speed, high torque burr, because if there's high speed, it generates heat and that causes bone necrosis and skin problems. But a high torque is important because you want to cut through the bone. And many companies today will manufacture MIS boxes, burrs that will accommodate these needs, and the mini C-arm. So you basically have the kit for the osteofiber TTFN nails or screws. You have a burr and you have a mini C-arm, and that's really all you need. It can be done as an outpatient surgery center. For the MIA cases, we use different size burrs. So there's a Shannon burr, which is made to cut bone, not soft tissue. A 20 millimeter burr is used for metatarsals. A 12 millimeter burr is used to cut phalanges, like the proximal phalanx. A wedge burr is used to remove and resect bone. And as you do more and more of these cases, you'll become very familiar with these different burrs. But really, these are the three main burrs we use for the MIA surgery. There's also specialized equipment that you need for bunion surgery, sharp elevators, curved elevators, a rasp, and a translator. But we could, use all different types of stuff for this. But this is basically the stuff. So let's talk about these steps. So wires and screws are placed really along the first metatarsal. So that's the key. So when you start these cases, I usually outline the first metatarsal because, again, we're not looking at this directly. We're looking under C-arm. Step one is the key, and there's different ways, there's different approaches, but this is my approach, and this is the way that I teach residents and students for years, that we start with the K-wires, because the placement of the wires really dictates the rest of the case. So for the MIA case, we use a 1.6 millimeter K-wire that comes in the kit. We start at the base of the first metatarsal with just a little poke incision. You create a working space, and that pin goes from proximal medial to distal lateral. And the key is to come out that lateral cortex. It's important to look carefully on the AP and the lateral because you want that pin to come out of the lateral cortex. If it doesn't come out of the lateral cortex, then you're not going to get the fixation you needed. These fully threaded osteofiber TTFN screws and nails, they need to bite into the lateral cortex to get fixation proximally, laterally, and into the metatarsal head. So we'll spend an extra few minutes making sure that our pin is in the perfect spot. Then we place the distal 1.6 K wire. It's typically a centimeter distal to the first K wire. It's parallel roughly, and this one stays intramedullary. We use this one to deal with rotational controls and for extra fixation. Once our pins are placed, then we make the osteotomy. It's made with a little stab incision using a beaver blade right at the flare of the metatarsal neck. You take a little elevator, a key elevator, or a sharp elevator, elevate the soft tissues just wide enough for the burr to go in. So it's 1 to 2 millimeters. You're not stripping soft tissue at all. So you're preserving the blood supply of the metatarsal head, which really encourages and enables fast healing. And then once you have your working space, it's all done intraosseous. So you're taking your burr, putting it into the bone, and then everything is done through the bone. I want to go over a couple techniques that's really important. It takes practice, but this is key. How you handle the burr is important by either lengthening, shortening, or plantar flexing the first metatarsal. So here's a drawing. If you take your burr through the metatarsal and you angle it just slightly, about 20 degrees, when you complete the osteotomy and you slide the metatarsal head over, that essentially ends up equal or parallel to where it was before. Now, sometimes if you have a long first metatarsal and they're getting sesamoid problems, what have you, you may want to shorten the metatarsal. So you can enter the bone from the medial side, aim more proximally, and after you make your osteotomy cut, your metatarsal head is sliding laterally and also shortening slightly. There are times when you have a long second metatarsal and they're getting metatarsal 2 pain. So they're getting calluses or even a hammer toe. I will say that the majority of the time in the last 5 to 10 years when I've been doing this operation, when I have sub 2 metatarsal pain or metatarsalgia or second MTP capsulitis and a bunion, when I lengthen the first metatarsal just slightly, as in this drawing, my sub 2 pain, my second MTP joint pain goes away. So the number of while osteotomies and shortening osteotomies I used to do have gone down about 90 to 95%. It's quite amazing, just with this little technique. Sometimes you may want to plantar flex the first metatarsal head. And all you do that is you start your burr cut dorsal and you aim slightly planar, and the metatarsal slides plantarly as well. How about the original description by Redfern and Van Ra with a chevron osteotomy? We've been doing transverse osteotomies, and is there any literature to support that? Well, I think there is actually. Lewis came out in 2023, looked at the difference, and this has been my experience as well. When you do a transverse osteotomy, number one, it's much easier to do. Number two, in a triplane deformity, if you need to relocate the sesamoids, what have you, then it's easy to rotate your hand with a transverse osteotomy. With a chevron osteotomy, there's minimal cortical contact. You have to make sure your pins and screws are in the exact perfect spot because you have less bone to work with. So I usually teach a transverse osteotomy. I think it's easier to reproduce. All right, you've placed your pins, you've made your osteotomy, you've decided whether to lengthen, shorten, or make it transverse and slide it over neutrally. Now you need to translate your metatarsal head. You can use a freer, you can use a joker, you can use all kinds of specialized equipment, but it's not very difficult. You put your tool in the metatarsal shaft, you push your metatarsal head over, you rotate your hand if you need to, you rotate the toe. That's how you do the triplane deformity until your sesamoids are reduced, and then you advance your pins. So this is an ideal placement of your parallel pins. Notice that the first pin is coming out the lateral cortex, the second pin is coming intramedullary. And then once I translate my metatarsal head over, I then advance my pins. I want to check on the lateral as well, because one mistake that can happen is that pin can end up plantarly, can end up in the sesamoids, and that is definitely a problem. You want to do that. Once you get your 1.6 K wires in the metatarsal head, you're going to measure your length, you're going to drill the screws, then you're going to exchange the 1.6 for the 1.1 K wire. For those of you who've done this operation using other screw systems, this is the main difference, is that the screw goes over the 1.1 millimeter K wire, not the 1.6. The reason why we use the 1.6 is because there's less skiving. It's easier to place the 1.6 in the perfect spot. To change the 1.1 is very simple. It takes 5 seconds, and it's at first it seems like annoying, but it's really very easy to do, and it's well worth switching it over to use this fixation nail. So step 4, you've now placed your pin, you make your little stab incision, you measure over the 1.6 K wire, you measure your pin, and then you take your osteofiber. It's one implant that comes in the kit. You don't need a tray of multiple sizes. You don't need lots of disposable size that you open up and you waste. This time you take one implant, You measure it, you cut it to fit, and there's a specialized screwdriver that fits over the beveled screw that's lined up with the bevel, so you know exactly where it is. And this is the fun part. It's like we were in fourth grade. You get to actually sharpen the end of the osseo pin. This is one of the fun parts of the case. The screwdriver extends out to the end of the osteofiber nail because again, this is a bioabsorbable, but not only that, it's radiolucent, which is really amazing. So you're actually not seeing the metal on the x-rays, which I'll show you in a second, which is pretty amazing. So then you drill over your K-wire, you exchange your K-wire for the 1.1 K-wire, you pull out the 1.6, and then you insert your screw. Step 8, same thing, you repeat the steps, you measure over the 1.6, you cut the nail, you drill, you exchange the wire for the 1.1, and you advance the screw into the metatarsal head. If you have a small metatarsal, you can also use a 3.0 nail, whichever fits better. I tend to use two 4.5 nails. I find that those are stable, they're very strong, the fixation is incredible, and I've had no troubles with breakage or any problem with immediate weight bearing. And that's what it looks like. So it's kind of amazing, right? On the left, you can see the shadow of these nails. I had to adjust the X-ray density just to show these screws, but usually they're really invisible, and patients are amazed. Like, oh my God, doc, this is a crazy looking X-ray. These bones are just floating in space, but they're really not. You have really excellent fixation with these two nails. I would say the majority of the time we're doing an achinosteotomy. This is done in a similar manner. And I place my K-wire first because I think that's the most difficult portion. You check on your AP lateral, making sure that you're in position. You make your stab osteotomy, a closing wedge osteotomy, either with a burr, a 12 millimeter burr, or if you need a big correction, you can use a wedge burr. You correct the deformity, you advance your K-wire, measure, drill, bicortical, and then you put your osteofiber screw in. For this case, it was a relatively small phalanx. I used a 3.5 millimeter partially headless compression screw. You can use the 4.5 if it's a big one. You can use a 3.0. I prefer the 3.5 in these cases. That's the operation. Then you're done. Now, once in a while, you have a little extra shelf. I'd say that happens about 30 to 40% of the time, maybe more. And we just take a little burr and just burr it down through the percutaneous hole that you'd used previously to put in your screw or your osteotomy. Rarely do you need to do a lateral release. When we were taught to do bunions way back when, they were done with a lateral release first. Almost never a lateral release is required with this MIA surgery. The correction is amazing. You don't really need to do lateral release. And it's the final achinosteotomy. Again, it looks like this floating bone in space, but it's really not. You really have excellent fixation. So here's case one. This on the left is what she looked like pre-op. This is what they look like post-op. This is the immediate post-op x-ray. It's really quite amazing. They're very stable, they're very strong. So in summary, in this case, we use the 4.5 proximal beveled nails for the metatarsals. We used a 3.5 millimeter screw for the achinosteotomy, and the picture on the right is when it's all healed. Final step, if there's a little excess bone along the medial metatarsal head, I take a burr through the previously made tiny pop little incision, burr it down, and this is the second fun part of the case. You get to morselize all that bone and just express all the bone paste. That's kind of fun. It looks like toothpaste, but that's a fun part of the case as well. So again, here's the case, the initial pre-op on the left. After the MIA is done with the osseo screws, there it looks like on the right. 3 months follow-up on that other case. You can see on the right-hand side where I circled, that's all the new bone growth that has grown around that osseo screw. Remember, we're not really violating any of the soft tissues. So the periosteum, the blood supply, everything is intact. And because of that, you get very, very quick healing, robust bone formation. These osseo screws, it almost seems like it attracts bone to itself. I don't think anybody's ever shown that or proven that yet, but in my experience, what I've seen is that these screws really promote ingrowth, probably because of the architecture, how they're made and how they're designed to allow the bone to grow into itself. It's pretty amazing. 6 months, another case, completely healed. The bone is completely remodeled. The screws can't be seen at all, and the patients are just absolutely amazed as well as the surgeon. The MIA surgery is fabulous. I mean, look at the incisions. They're stab incisions. There's no swelling. The motion is unbelievable, and these patients are extremely happy. Let's do another quick case. Here's a 61-year-old. She's had a painful bunion for many years. She's tried bunion splints, padding, shoe modifications, miserable, having a lot of pain. Here's what she looked like when she was standing. Here's her pre-op x-rays. I'd say it's a moderate to severe bunion deformity. This operation was done similar with two 4.5 nails. The Aiken, this time I use a 3.0 nail. At 1 week, this is what she looked like. Again, this bone appears to be floating in space, but it's not. The osteofiber screws are really holding it unbelievably strong and rigid. By 4.5 months, the bone's completely remodeled, walking, having no problems at all. And this is what she looks like. She's happy. She's back to full activity. She has full range of motion. She's back to her normal shoes. Summary, another case, pre-op on the left. This is what she looked like by 4 weeks. Look at that. There's almost no swelling. You're already getting wrinkling in the skin. You're already seeing some bone remodeling around these osseo screws. Really, they're promoting bone growth, and it heals very, very quickly. So a couple little tips that I've learned, and I'd want to share with you is number one, train. Use new burrs. Use specialized equipment. Don't shorten the operation by using what's ever in the room. Ask for the low speed, high torque burrs. Cooling it so the burrs don't burn the skin. Practice. The protocol: first 2 weeks, expect some bruising. They can be full weight bearing in a boot. Start working the range of motion. By 3 to 6 weeks, they're already on a stationary bike. They're walking. They're exercising. They're still wearing a protective shoe or boot. By 6 weeks, they're back to normal shoes, and they're basically doing activities as tolerated. And that's been my experience my entire journey. We wrote up our first series of patients. It was presented in Spain in 2025 last year. We looked at 18 patients with follow-up. We had no hardware problems. We had no revision surgeries. We had no reactions to the osteofiber screws. They were able to get back to their function very, very quickly. And the patients were extremely happy. That led to me doing more of a robust study. We have a consecutive retrospective study and an IRB-approved prospective study. So we went through all the rigmaroles and all the protocols of getting an IRB-approved study to prove that these work, as well as I've seen in my practice. These are the preliminary results. We're in the middle of collecting all the data and publishing it. So far, I have 68 patients. They were all fixed using osteofiber nails or screws. They all had immediate weight bearing in a boot, allowed to drive in a post-op shoe. Average follow-up is 17 weeks. Some are more, some are less. We looked at promise. We're looking at promise scores. We're looking at weight-bearing X-rays. To be fair, to be objective, a third-party, unaffiliated surgeon is actually looking at these to make sure that there's no bias involved. These are our preliminary results so far. At an average of about 17 weeks, we've only had 2 cases with a superficial infection that resolved with some antibiotics. The corrections were incredible. We had almost a 60% correction in hallux valgus angles, a 32% correction in IM angles. Our promise scores were pretty impressive. Really, by 4 months, we had a 22-point average improvement in FAM scores and a 4-point average in VAS scores. So these were happy patients who looked great and felt great with these screws, with these operations. So in 2026, this has become my algorithm. And this is, again, 26 years of trying everything under the sun. I do a minimally invasive bunion correction in the vast majority of patients with bunions, no matter how big this is, unless there's arthritis, the first MPJ, then we do a fusion. If there's first tarsal-metatarsal joint instability or arthritis, then we'll do a lapidus. Or occasionally, if the deformity is so bad that there's no space to translate that first metatarsal head, in other words, it's just too big, then I'll do a lapidus operation. And really, that's become my approach and has been very successful this year. So, in summary, I think minimally invasive bunion surgery is here to stay. I think it is the gold standard. These patients, especially using osseo screws, have a quick recovery. They have very little pain. There's very low incidence of complications. There's no problems that we saw with metal. And really, this 5th generation MIA is really a win-win. The patients seek it out. They love this. I have patients come to me. They say, "Doc, I don't want any metal on my foot." I mean, it's great for marketing, and that's a sidebar. We have had no issues with the metal. We have no rejections. Revisions are easier. You can actually cut through these bones. I've not had to do that, but if you need to cut through the screws, you can cut through the screws, unlike metal where you need screw removal sets and they strip, and it's a disaster. We've all been there. Trying to take broken hardware out is a disaster. With osseo screws, that's not an issue at all, ever. And that's the story. So thank you guys. Any questions, please feel free to ask, and now's a good time to chat. That's about the end of my presentation.
Neufeld, here's one question. Have you encountered any complications or non-union cases?
I have not seen. I've had a couple delayed unions, but it's difficult because you're not seeing the metal. Uh, I'm sorry, you're not seeing the osteotomy with metal, so you don't really even know about the non-used delayed unions of metal sometimes. But with osteofiber, it's actually you can actually watch the fusion week after week, month after month after month, so you can really judge it carefully. So I'm a little more critical of my osteotomies. I look very carefully. So I would say radiographically, I've seen some delayed unions where they haven't healed in 6 weeks, but clinically, I've not had any non-unions. They've all healed, and by 3 months, 4 months, all those osteotomies have healed without troubles.
Here's another one. How do you handle the demographic that have met adductus along with the bunion?
Great question. Um, I do percutaneous. It depends. If it's metatarsus adductus with arthritis, then we have to do a fusion of the TMT joints, second and third tarsal metatarsal joints. I find the vast majority of metatarsus adductus are like this picture below, where it's a mild metatarsus adductus that is somewhat flexible. And in those cases, I will push the envelope to do a MICA or a MIA. If there's just not enough room, it's a rigid deformity, then I'll do percutaneous osteotomies, closing wedge osteotomies along the lateral portion of the proximal metatarsal. So I'll do those first, which essentially frees up the second and third metatarsals, sometimes fourth. Those metatarsals are now free to move over, and then I'll do like a lapidus, usually, to stabilize the medial column.
Here's another one. What do you think about using one screw?
Um, it makes absolutely no sense to me at all. There's no reason to do one screw. Um, it's all about fixation, and you need rotational control. You can't get that with one screw. Impossible. If you don't have perfectly strong bone, which many of these patients are women that are postmenopausal, you have some osteopenia, you need two screws. There's no way that one screw is going to give you enough fixation. It's just impossible. I've seen many failures of people who try to cheat the system and use one screw. You lose fixation, you lose rotational control. You have to be much more careful. You have to keep them non-weight bearing, and to put that second screw in is not very difficult at all. And I see no reason to do one screw. It doesn't make any sense at all. You're just asking for trouble. You may get away with it. You may get lucky with somebody who's very, very good bone, like a young person. But why gamble with somebody's foot? You have one shot at making it perfect. There's no reason to do one screw. It makes no sense.
So if there is a revision, you're saying we can create an osteotomy through the screw?
One of the best parts about these osteofiber screws is you can cut right through them. I mean, again, this forms bone. So if you ever have to revise it, or you have a non-union and you want to, or a malunion or something, you can just cut right through it with a burr or a saw. You don't have to take it out, which is great.
Why not Aiken from distal oblique approach? Any difference from staying out of first MTP capsule?
No, no reason. It's just the way that I'm comfortable and I do it, but there's no reason not to. It's fine.
With metal hardware, I have patients in a sneaker at 4 weeks, and some of my colleagues have them in a sneaker at 3 weeks. Do you ever see yourself transitioning them to a sneaker in the future at 4 weeks?
Um, I don't. I mean, I've been doing 6 weeks the whole time. I guess if it's a younger person who is not osteopenic and I have good fixation, sure, I don't see why not. I probably would add a carbon fiber plate to that sneaker at 4 weeks just to be extra safe. You know, the difference between 4 weeks and 6 weeks in somebody's life isn't that big a deal. So I think I'd rather be a little bit more conservative. Um, Many people have osteopenia or softer bone. My only cases where I've lost some fixation is little old lady bone. Usually their results are fine, but it makes me nervous as a surgeon. So I don't think there's any reason to push the envelope and make it any faster. I think these MIA cases are so incredible and they are so much better than the old open surgeries that the difference between 4 weeks and 6 weeks makes no difference. Like, who cares? What's the big deal? I let them walk on it right away. They walk in a post-op shoe at 4 weeks. But yeah, I guess for a young person who's really pushing it, we're in Washington D.C. We have lots of people, lobbyists, politicians, want to wear their fancy, shoes and their high heels and Ferragamo's. Sure, if they push me, and they have really strong bone, and I feel pretty confident, I guess I would consider it. But by rule, probably I'd just wait.
The only questions for now.
All right. Well, listen, guys. I would encourage everybody to try this. The operation is fabulous. These screws are fabulous. Your patients are going to love it. They're going to come asking once they learn about this. They're going to come asking for this screw because nobody really wants metal if they don't have to have metal. I mean, I for sure wouldn't want it. So
Indeed.
good luck with your training, everybody. Thanks for tuning in.
Thank you, Dr. Neufeld.